Can digital health, AI, and emerging technologies truly help save the NHS? Yeah, that is a huge question. Right now, the NHS is operating under immense pressure. Rising demand, workforce shortages, and stretch budgets have pushed the system to its limits. In that context, digital health and artificial intelligence are often described as game changers, tools that can streamline services, personalise care, and unlock new efficiencies. But can they really deliver on that promise? And if they can, what will it take? So, to help us understand more, it's my pleasure to welcome our panel today. We have Dr. Mark Tucson, a lecturer at Cardiff University. Welcome, Mark. Good to have you. We've also got someone else from Cardiff University, a professional of operational research. It's Dr. Daniel Gartner. Welcome, Daniel.
Thank you for having me. Hello.
Hello. We have clinical lead for primary care digital delivery at NHS South East London Integrated Care Systems. We have Dr. Matea Delu. Sorry, apologies for the surname. Hi, welcome, Matea.
Thank you.
Finally, we've got Dr. Eleanor Wicks, honorary consultant cardiologist at Bart's Heart Centre. Welcome, Eleanor. It is the question that everyone talks about when it comes to digital health with the NHS, and it's about AI really being that realistic tool to support, the NHS. And I'm going to start with you, Eleanor. We're going to talk about the AI landscape at the moment. What are we actually working with at the moment? What's the present day landscape like?
Well, so obviously there are a range of kind of key use cases that we have and potential benefits of AI and digital tools in the NHS. Examples include opportunities in clinical decision support and triage, diagnostics in detailed phenotyping, which is kind of deep assessment of someone's presentation, risk stratification, remote care delivery, admin automation, data analytics. But actually, from a practical perspective, there are quite a few specific examples that people may not be as well aware of. So, for example, we're trying to digitize some care pathways, particularly in heart failure and cardiometabolic disease. And some of the work that we've been doing in Oxford and in primary and secondary care, along with Life Year, has been trying to look at the benefits of remote monitoring tools to detect disease in an earlier setting, to try and detect decompensation early, and to try and think how we can integrate scalable, low-cost solutions that empower patients also in self-care, which is obviously a critical component. But there are many different aspects. So we have virtual wards, we have hospital at home, we have digital twins that can try and integrate complex big data, AI ECG analysis, so the electrical tracing of someone's heart. We now can use AI to try and detect the disease before it even arises and someone becomes symptomatic. We can analyze images using AI approaches, and we have other kind of really cool avatars, and we have this European Society of Cardiology kind of chat now that tries to help support healthcare workers in using clinical guidelines to improve the care of patients. There are, co-pilots to try and help support us. I mean, the reality is tech is enabling us to do a lot more, but we really need to think about how we best embed it into practice on a day-to-day basis.
Matteo, when you hear Eleanor talk like that, we have got a lot going on in the NHS, and people may be thinking, oh, we haven't got this, we haven't got that, but there is so much that's being done already. So is it a case of getting what we have already, just improving that, or is it a case of we need a whole new reset of so many different tools?
I think what Eleanor's kind of described really kind of reflects the sophistication of what's possible in secondary care settings. When you have like structured data and sort of a dedicated informatics resource. If I take this to primary care, we're slightly different, and obviously our use case settings are very different in that respect. And in some ways, almost the opportunity is greater because for us, I would say the admin burden is higher relative to kind of the resource available to manage it. And actually, if I think of an example of what we're using right now, so I think probably ambient voice is a really good example to kind of draw on of where we're taking it and what we need to see kind of next. So ambient voice is not about seeing more patients. It is really about giving back clinicians that cognitive space to kind of really be present in a consultation rather than, managing any sort of data entry tasks, which we're very accustomed to do. So from my experience and from a lot of the evaluations so far, can return anything up to 10 minutes at the end of a consultation or at the end of a day to kind of allocate towards things that like admin that you now have more time to do. Other tools that are quite exciting in primary care, obviously using AI and machine learning models to identify high-risk patients. Now, what else is there? I mean, there's quite a few bit more. You've got so AI risk stratification, so you've got ambient voice actually for patients, so using AI sort of chatbots back and forth. So there's quite a lot out there, quite a lot of really good use cases. I think what we're doing with it now is very much, we're piloting it, seeing how we can build an ROI on all of this, so that actually we can implement it at scale moving forward. I think one of the things that my experience with ambient in particular is that the ROI case has to be built differently to how commissioners are used to thinking about it. And in particular for primary care, it's very difficult to beg the case that ambient is going to make us see more patients, and the return on investment is around being able to see more patients, and that really doesn't frame and that really doesn't translate to us. What we're actually talking about is like a chain of value that operates over a longer horizon, and so we need to start looking at, when we look at things at scale and we look at the ROI and we look at these types of use cases, we really need to start thinking a little bit differently. And ambient AI, I think, is a really good example of how our mindset needs to start changing to kind of build it out at scale.
It's almost like you need the AI to support the controllables. And if when you come to primary care, it becomes more uncontrollable, and therefore it becomes more difficult, right? So it does make sense that the secondary care is easier, and I've got I've got mathematical modelling to be, how can we use mathematical modelling in the NHS to improve services? I mean, this is something that would we ever have thought about using this to create a better NHS? Daniel, I'm going to throw that to you because I'm mathematical modeling.
Yeah, so mathematical modeling is a discipline in applied mathematics, but it spreads across computer science, business administration, etc. In the use in healthcare modeling. And what we try to understand is the interconnectedness between the different parts of the system. For example, GPs referring patients to hospitals. What does that mean to the demand coming in? Winter pressure planning, mental health waiting lists, dental, etc. Geographical modeling. Why is that in one part of the country people are waiting 10 times longer than in other parts, etc. So all aligning demand and capacity in a model that tells us, what if we did resource alignment differently, or if we planned winter pressures differently, what would happen then on the ground? Yeah.
So mathematical, if I get this right, mathematical modeling is for the what ifs. So predictions.
Exactly. So we have a computer model, a simulation model, and then we can run different scenarios. So, for example, what if we aligned shifts differently? Would we see a reduction in waiting times at that particular time of the day? Things like that is what we can do with the scenario analysis. Exactly.
Slightly better than a crystal ball, then, are we saying? It's not quite predicting the future like that. But it makes sense, though, Mark. And, and it does, although we can't predict everything, it helps, right? We need to start doing this. Otherwise, with the NHS, what it is, I mean, what would happen if we don't do this?
Well, okay, so I spend about 50% of my time embedded in my local health board, doing the forecasting, the capability and capacity and demand.
Mystic Meg. We call you Mystic Mark then. You are the Mystic Meg. I knew it.
I'm going to promote that in the next thing, because it does sometimes feel a little like that, because mathematical models, they're really good, but most of it is the phrase we often use is stochastic. Okay, in the sense of, we can turn around and say, in the next month, you would reasonably expect to see X number of patients in your ward or whatever it might be, and give or take a bit will be right, but it is give or take a bit. And I think when you talk about Mystic Mark, whenever I start saying it's a give or take a bit, people start to get worried about, we want certainty. You're a mathematician. What's the right answer? And the reality is, we give the best answers that we can. But the other thing, Daniel, I think, was slightly understating the case a little, because my colleagues have worked on things like waiting lists. What's the optimum strategy of that? I and another colleague are currently looking at the best strategies in an ICU to maintain sort of bed openings and things like that. So it is a very broad field. I'm going to shut up there.
No, don't shut up. This is what we want to hear about, because when you come from, when we're not involved in the work that you're doing, it's hard for us to understand. So it's good that we are learning more, because and I'm guessing, Mark, and when you haven't predicted something right, people then have to go, well, you said this, and then and then it's just like, well, actually, this is what we're doing is trying to look at the bigger picture. This is how we're trying to predict the best we can for the best outcomes for the NHS. And I think that's what sometimes, and this is why we have these discussions, because the NHS, it becomes, we all feel it. We all feel part, it's our health, it's our NHS, and we get very emotional about it. So is it the best place? So I'm going to look at like sort of the NHS. Is it best to, in anyone's opinion, to work with AI diagnosis? Should we concentrate more on waiting lists and workforce allocation when it comes to AI, or should we go more in the diagnostic side? Is it, or do we need, because that's where people are going to be a little bit, we got this on one hand and this on the other hand. Should we focus more on one on the other? Who wants to take that? Eleanor, you're gonna
yeah, I'm happy to. I think you have to do both, because it's like having two diseases and treating them in the same way. You can't. They have specific tools, specific solutions according to each parameter. And that's why, even here today on the panel, we have different people from different areas so that we can bring together that expertise, and it's exactly the same.
Yeah. I think that's why it gets, and then if you've been in, and I'm fortunately, my son was involved, and we were within the NHS end of last year. We were quite embedded in it, and you do see it when you see it, you're in it, you see it, you need both. It's just obviously when you come from the outside, you think, no, waiting lists, we need them down, we need more nurses and everything like that. But what about these systems? Do they work well together? Because I'm going to ask that, and Matteo, I'm going to ask, we've got all these systems, we've got those the waiting list and everything. Do they complement each other, or is it still a bit fragmented?
I think we'll all probably confirm in this panel that it's all pretty fragmented still. So, we've got multiple legacy systems. We've got a different EPR system across the country. We've got kind of two main players and a new emerging one. In secondary care, it's even more than that. They don't talk to each other, which is the unfortunate bit. And then you've got the community systems, which are also very different. So imagine where you're a patient and you go to your GP and your GP holds your data. You then go to urgent care. Urgent care cannot necessarily access, although we are getting better. And I think London's a really good use case, because through One London, we've got the London Care Record, where now you can start seeing data from general practice. You can start seeing data from other hospitals being in one system. We've got GP Connect, which is the primary care initiative, which now we're also trying to integrate more with pharmacy services. And with that, we've been able to integrate those in hospital systems. So if you're an Epic user or a Cerner user, you can have access to that data. However, you still need to open up a different system to be able to see and track, and it's not automatically just pushed. And what that kind of creates is what we talked about, this fragmented system, and a lot of it is actually due to the fact that these legacy systems don't allow for integration and interoperability. We've had a lot of issues with that in countries like the US, for example, where it's mandated that any system needs to have interoperable APIs. It becomes a little bit easier, and I've seen really good examples of an entire primary care to secondary care system sitting on one EPR, being able to share that data. Where I think that where we're heading to, and where I think it's really exciting, is obviously the whole focus on the NHS app, because NHS app now is the kind of it's the platform for your data. It's the platform where you've got all your GP data, you've got your hospital letters coming through, you've got your pharmacy, your medication, and actually the NHS app can be looked at. Is this as the ambition going to be a kind of single source of truth? Yeah. So there's a lot of excitement there.
Okay, I'm going to throw this as well. If you've got all these different systems, surely are they safer because they're different? If you get them all talking, does that mean that they are less secure? I don't know. Anyone wants to say
I'm
that?
I'm not sure that's the debate I'm hearing at the moment.
No. Oh, that's good, Mark. I'm glad you said that. That's fine. I just thought I'd say it because I know in my head it'd be great that we had this one, everyone talking, the systems talking to each other and everything's connected. But then in my head, it's like, well, actually, does that make it more secure or less secure? And data as well. That's you feel a little bit.
The focus I see is all about. I think, as Matteo said, these systems were originally designed for different purposes. They were designed for record keeping, for audit, and the real thrust of the effort I'm seeing right now is about bringing them together, putting them all in so they're accessible from one point.
They have to, don't they? I mean, it sounds so easy and it sounds so, simple. Are we in? Okay, obviously. Look at me going. It's really easy, and I have no idea. I'm not an AI expert, but are we trying to run before we walk? Basically, is the question. Have we got all these fantastic systems and in place, and yet actually we'll just talk to each other first?
So this is actually a term I'll pitch into this one, and then obviously I'll let anybody else, but this is a term that I've been recently talking about, and I call this, when you've got systems that talk to each other, I call this the longitudinal care record, or the longitudinal record, so it moves across. Now, when you've got this, what the longitudinal record does is it eliminates a particular category of clinical error and inefficiency. So when, for example, like when I as a clinician can see what happened at the hospital, when I've got a full medication history, when I don't have to rely on a patient's sort of recall for anything that we're told like 3 years ago by a specialist, that genuinely changes the safety and the quality of individual clinical encounters. So that we're talking about clinical safety and we're talking about all of that. It also enables, like having that, it'll enable things like population health analytics in ways that fragmented systems cannot. So as I mentioned earlier, we can kind of identify which, cohorts are at highest risk of hospitalization. We can target interventions earlier and we can evaluate whether those interventions are working at scale. But you can only do that if you've got that integrated system, because your data can follow the patient. So what you do, what intervention you deploy in one part of the system, you can track that result and you can track that outcome with that patient as we move forward. Right now, a lot of when you look at evaluations and you look at a lot of our KPI metrics, they're on a population level. So you get a sense, but you actually cannot tell whether actually you've made a difference to a patient, or we call it personalisation. So that's where we've been talking a lot about the longitudinal care record and how that can kind of work in that sort of space with interoperable systems.
Yeah, no, it makes sense. And and with all this, and Hatim at the start, the keynote was very much about that human element first. And we have to remember, a great AI, we can get very carried away with it. But it's that patient care at the center. Patient first, patient first, patient first, before anything else. Because if that is lost, then there's no point, right? There's no, the patient, mistakes will be made, errors and everything like that, because something will be missed or whatever. And it is about that patient journey that's the most important thing. But predictive analytics, Eleanor, you talked about it. I like the diagnostics and analytics and everything like that. It's so exciting. I mean, what's going on at the moment that's like really exciting you?
Okay, so
Ooh,
sorry,
Eleanor, carry on.
So I mean, to me, it's I think it's the preclinical diagnoses and also defining precise disease diagnoses. So we have red flags that may arise before someone has symptoms, and we need to get kind of proactive rather than reactive. So at the moment, we deal with a condition when someone comes with swelling of their legs, breathlessness. We're dealing with a response to a disease process that's already well set in. If we can get into the proactive phase by being able to detect things at an earlier stage, then we can deliver more speedy diagnoses, which ultimately improves morbidity and mortality, rather than waiting downstream. And then there are, the different components of optimizing what already exists. You come into hospital, you have a heart attack, you go home, you're on 5 tablets, no one ever checks your cholesterol again. Or if it is checked again, the medications aren't optimized to prevent you going in with another heart attack. Yeah. So we really I think it's predicting the prediction of who is at risk, as we've already mentioned, and how can you target those, reduce the risk to prevent further downstream effects, but also enabling people to manage some of their healthcare themselves, be it with digital support and prompting and alerts to kind of say, actually, your blood pressure's out of range today. Try and tackle it. You need to follow these lifestyle measures. We can do that now with the technology that we have. We're just not very good at using it.
Mystic Mark is loving this. He loves the prediction. Mark and Daniel, from your point of view as well.
I think that there's partly so predictive analytics in my world means something slightly different, but so the thing that's happening now is going back to Mattea's longitudinal record. That's allowing us now to start from the other side, start forecasting things like length of stay. I'm doing some work right now on incidence of pressure ulcers, and how we can forecast them and how we can minimize them. You know, so that longitudinal record really works well for that sort of side as well. So it's both sides of the coin is what I was going to say.
Yeah. And Daniel, for you as well, predictive analytics, is that, I mean, what's working in your world?
I think it's the mix between improvement and predictive analytics as well, or analytics and improvement, the integration of both, because we also want to measure at the end how successful was that intervention. And, you know, with a plan, do, study, act cycles, how can we make then even a better improvement then further down the line? But I think going a little bit back, sure, like patients, super important to you know, to apply these analytics methods to, and etc. But also the staff component is very important to, you know, minimize burnout, or, you know, to make sure that staff can work shifts that they like shorter shifts, longer shifts, or, you know, working patterns, for example. Just you know, with an exercise that we did with intersite transfer modeling, we were able to align these different shift schedules better to the demand patterns, and then, you know, make then an improvement in terms of the waiting times that patients have when they wait for their transfer to the next critical care center available, etc. So this is something where the whole staff view has to be incorporated, and is very important as well, I just want to say.
Yeah, no, absolutely spot on. And it is, you know, of course, what we've seen whenever we have these discussions as well, the importance of getting the staff on board as well, you know, keeping them on the journey as well, because it can be quite scary for the staff, you know, those that haven't been used to it, you know, all these different implementations. And I love the fact that we're still in pilot schemes as well. You know, there's lots of case studies and pilot schemes going on, which is great. And lots of studies we're showing we can do this, and this. But then there seems to be a bit between, we're still in pilot stage, you know. Mattea's like, yes. Okay. I do feel like when we have these discussions with the NHS, it's always pilot. I mean, what's stopping this from really taking off? Why is there a gap between pilot scheme and actually embedding it into NHS culture?
Several things, I think, and I think it's really worth being direct about it. And I'm here to be direct about it. So firstly, I'd say, you know, procurement and governance cycles are just really misaligned with the pace of technology development. You know, by the time a pilot has been evaluated, the product has generally moved on quite significantly. Second, you know, the incentive structures do not really reward adoption at a system level. They reward what I would say innovation at a project level, which is the two very, very different things. And we sometimes kind of mix them up. Third, and I think this one is probably the one that doesn't get said enough, we do not invest enough in workforce capability needed to sustain the actual implementation. You know, we train people to use the tool during a pilot stage, and then, you know, wonder why adoption dropped when like a project team leaves and just says, okay, well, we'll just leave it with you and let you just kind of get on with it.
Right.
From a primary care perspective, I think, and we've got a specific problem around fragmentation of the entire landscape. So we've got hundreds of practices, and I'm talking about Southeast London, making independent procurement decisions, often without any sort of clinical informatics support to evaluate what they're buying, and without any sort of system level view of what has already been assessed and found safe. And that really kind of hinders that ability to scale something, because you don't know where to turn to. You don't know what's safe. You make that decision on your own, and then you realize, actually, and we saw this with ambient AI in June of last year, it just went a little bit just a bit wild, and we thought, okay, we need to stop and reevaluate how we're implementing these tools. And, you know, so a lot of that is, as I said, it's not a recipe for scale, it's a recipe for duplicated effort, variable quality, and what I call clinician fatigue. And I think Eleanor will agree with me, just clinician fatigue with technology.
Absolutely.
Yeah.
Absolutely. It's like bureaucracy layers as well. It's you know, trying to scale something through, or to do a quick service evaluation pilot. You know, yes, we need the evidence base, absolutely, but to implement even a pilot is incredibly bureaucratic. You know, one of the real blessings of COVID was some of the red tape was kind of ripped down, which was a real blessing, I think, because there was amazing innovation that came through as a result.
Yeah. And I feel your pain. I genuinely do. And, you know, I think it's shocking. And I want to say there was obviously that gap for a reason, you know, and it's the health, and there's obviously governance and compliance. How do we speed it up though? Is there any way, Mark and Daniel, is there any way we can just Mark's, come on, Mark, you're supposed to predict the future. Is there a probability that this will be better in the future, or is it just because the definition of madness is doing the same thing over and again and not learning from it, basically? Are we still in this cycle in the NHS like this?
Okay, so I have less experience of the primary sector, so I'm talking more of secondary care now. What I see is the real issue is prioritization.
Okay.
The real issue is every winter we have an emergency and everything gets dropped for that reason.
Yeah.
And so for me, for example, the board, the healthcare thing I work in right now is working really hard to bring all the data together into a single source, but it serves 500,000 people, and I think there are 4 people working on that.
No, I've got the maths on that, Mark. I did some maths there, and that's a lot.
Yeah, exactly.
Thank you.
And they're also involved in other things as well. So it's more like the pressure is politically, it's just from we're a healthcare service, we look after people, that comes first.
Yeah.
And maybe there's also just an element of, actually this is not really my job. My job is to look after the people, look after the patients, look after the people.
Yeah.
I sometimes see that. On the other hand, I also see clinicians who are really, really good at this.
Yeah.
So it's a bit of a mixed picture.
Yeah. Daniel, how about yourself? What's your biggest frustration with the pilot schemes to actually implement them and embed them?
Yeah, I think sometimes I feel I mean, when we teach Excel, like simple Excel models with pivot tables, it creates these light bulb moments. But I think, even my kids are using Excel at the age of 10 or so. Yeah. So then I think why are we talking then about AI and predictive analytics rather than just start to walk first before we try to run, and just slicing and dicing data sets you already have rather than I mean, sure, it all needs to be kind of put into effort for different reasons. I think that capability of understanding data is very important to understand what is my demand function, and how can we kind of rearrange shifts like simply to mimic that demand better with our capacity. So these are sometimes quick wins and easy tools available, really.
I know, and that's Daniel. We just love new things. We love new, exciting things. That's why Excel.
Course, yeah.
We want new, shiny AI things. But this is we've said this is the problem. It's what it is right now. But there has to be a bit of and I've mentioned it earlier about governance and safety. And, again, we can get carried away and we can do this. And then, okay, yes, there's that red tape, but it does bring us down for a reason. There is that safety element and everything like that. So is the NHS actually equipped to make these pilot schemes? We said, we love to do it, but actually, are they equipped to do them? Maybe the NHS needs a bit of if that makes sense. We talk about we want to do it, but actually is the NHS equipped to do it?
Well, I think the honest answer is yes, and I say this, I'm a clinical safety officer at the ICB level, but in some parts of the system, yes, and in other parts, not yet. And I definitely say primary care kind of sits firmly in that secondary category. So as a clinical safety officer, I work a lot with, DCB and hazard logs and all of that. And what I would say is, so the DCB 0129 and the 160s, they provide a foundation for that clinical safety assurance, and for acute trusts and large system suppliers with dedicated clinical safety officer and governance, that's pretty workable. The problem is that those standards carry embedded assumptions about organizational capacity that just don't really hold in primary care. So we've got, I think, somewhere around 7,000 GP practices in England, most of them small businesses, being asked to adopt an increasingly complex technology landscape without any of that really kind of support or the dedicated safety resource. And what that kind of produces is a fragmented picture. So some practices with robust kind of local governance, whether they have it at a PCN level or a super partnership level, and then ICBs like ours trying to build kind of interim solutions that should not really need to exist if the national framework were kind of appropriately sort of tiered from the outset. A single-handed practice that wants to adopt an AI consultation tool often doesn't really know that they need a clinical safety officer. And even if they do, the expectation to produce that hazard log, maintain it over time, and like really connect it to post-deployment surveillance, which that's the big one that's really missing, is that we'll implement, but actually post-market, post-deployment surveillance, which vendors do, they have to do as part of the regulatory framework. They have to do something called the PMCF. We need to, as the implementing organizations, we also need to be involved in this audit process of post-deployment surveillance, because these products will change, new models will come into play. How that affects your clinical decision-making, how that affects your workflow needs to constantly be updated. And we don't do it enough, but that's a lot of that is because of the lack of workforce capability and lack of workforce skill. So
So ironically, we need more of a workforce for AI and for digital transformation. Oh, we've lost Daniel for a minute. Which sounds like it's sort of counterintuitive, really, doesn't it? Counterbalance, but that's actually, we need that. We need people to implement the AI to help the workforce be better.
Absolutely. And it needs to start from, it needs to start from med school, it needs to start from nursing curricula, it needs to start from, one of the things, so I'm a supervisor for the NHS Clinical Fellowship in AI, which is really, really great initiative, because it's now giving junior doctors a year-long kind of experience where they're embedded into AI projects. They're really learning from us. They're becoming clinical safety officers. They're learning those skills that if they were to be the next leaders, which I'm hoping to kind of push them into, they can take that on, hit the ground running. And we need more of those types of initiatives, not just for junior doctors, for everybody.
Everybody. I know, and Mark, you're just nodding completely as well. But it is true. We say this. If you are investing in the NHS, it's not just about a shiny thing that's going to save 5 minutes here. It's people. Invest in people, help them, bring them on the journey.
I mean, you've got to include the infrastructure and the skills and the governance and engagement throughout, and to try and overcome some of the inertia that exists, I think, is because of the bureaucratic processes. But if we can break down the barriers to actually translate some of this and to upskill ourselves across the healthcare sector.
Yeah. And I'm gonna would you say this is the biggest crucial factor for this for success with AI in the NHS? People. And if we don't, because otherwise it sounds really, again, I said it earlier, if we carry on doing the same thing, well, if you always do what you always did, you'll always get what you always got, and I feel like this is we kind of do on this loop all the time. And Mark, it's got to be about people, right? And if there are no investment in the people, then you can't invest in these tools that are going to help.
I think Matteo said it very eloquently. It is. I think there's the people, and the time and the capability and capacity. I know Daniel and I have spent many hours trying to pass these skills on, but it is very much pushing the stone uphill. It's not really my job. Is often the thing we get.
Yeah. But it is, but it isn't. I know, I can see it and I can feel it, and it's right. And we have to start. I think, do people just think that it's AI? Are we a bit lazy with our AI that, oh, it's going to do it for me? So why am I learning about it? Does that?
I think the attitude that I see is, yeah, this is all really good. This is all really important, but it's not my job.
Yeah.
And to give a very simple example, I often do, we've talked about forecasting. Forecasting is an inexact science. You often want expert input from the clinicians to say, look, this is what the numbers are telling, does that work? And they look at you slightly puzzled. Well, how would I know?
Amazing. Okay, right. We've got lots and lots of questions. So what I'm going to do is going to ask one final question and sort of give your summary, and then I'll go into, we've got 10 minutes left. So what I'll do is I'll go to the last question, because I think I still love this question headline, and it is the title of the panel as well. And then I'll go and read through some of our questions, because we've had lots in. And thank you everyone for putting your questions in for our panel. So I'm going to ask that question. Can AI actually save the NHS? And we go around to all of you. There's no escaping this question. And I'm going to put it to you, and I want to see your honest opinions and your little summary of it. Because, yeah, and then I'll go to some questions. So, Ellen, I'm going to start with you. Can AI and tech save the NHS?
Well, as a digital innovator, I think whilst we need to be realistic, technology alone, I don't think will save the NHS. Because there are challenges that are structural: workforce shortages, rising demand, aging populations. But I think really what our digital tools and AI can do is to really help us use the limited resources more intelligently. Reducing administrative burden, improving triage, risk prediction, disease management more proactively rather than reactively, I think really can help us improve and develop a more efficient preventative healthcare system, which is really where we need to get to.
Perfect. Daniel, how about you? You're back. Thank you for coming back. Can AI and tech save the NHS? Your thoughts?
Yeah, I think saving is a little bit overstated. I think it can help understand what resources, for example, are needed to deliver services. Whether that's really implemented, then that's decision makers, responsibility then, because sometimes the money is not available, for example, if that is a big constraint, and then you can only deploy so and so many resources, but you can sometimes just use the model to understand where the gaps are in terms of the demand and capacity. Yeah, so it can be used wisely, but saving the NHS, I think it's a long way to go. Yeah.
Okay, I know it's a lot more than it. And I love the fact we've waited 32 minutes just to mention the word money as well. So well done. We did really well there for not mentioning money. And Mark, what about you? That question: can AI and tech save the NHS?
The NHS is about 10 years older than I am, so it's doing well is the first thought. But I think Alan has said it well. I think it can buy time, it can create space, but there are more fundamental issues and concerns that need to be addressed.
Yeah, and Mystic, and your new name, Mystic Mark. I'm claiming that.
I'm going to use that.
Yeah, definitely. Matteo, your thoughts?
Not on its own.
Yeah.
So, and I think we would do patients and clinicians a disservice if we suggest otherwise. And a bit like what was mentioned already. So what AI can do is buy that time and that capacity in a system that's really running out of both. Things like, I mentioned a bit of ambient voice returning about an hour a day, and I say that it's quite quite generous to a GP, drowning in admin. Things like intelligent navigation that we're working on, getting patients to the right place after first contact, predictive analytics, all those kind of cumulatively, those gains are real and significant, but none of that saves a structurally under-resourced system. AI does not train more GPs. It doesn't build more capacity, or can hopefully build more capacity, but it doesn't actually build capacity within a system, or it doesn't resolve the social care crisis that keeps beds blocked. So I would leave it on this, and I say if we let the excitement around technology substitute for some of those really harder conversations, we will have used like a genuine opportunity in entirely the wrong way. So I think the tech is ready. The question is whether the political will to make the structural decisions sits alongside it.
We've got goosebumps there, actually. That was good. But it's true. It's so true. We've got 5 minutes left. And I'm going to go through some of the questions. And like I said, we've had loads in. This is a question for you, Matteo. How can we use AI to help in the management of advice and guidance requests between primary and secondary care, which is so drastically increased, particularly for cardiology aspects like palpitations and reading abnormal ECGs, etc.? And that's from Amit, who is a cardiologist.
So there's some work going on around can we use AI to triage some of these advice and guidance requests? So not as a GP, and I know a lot of my colleagues will send, we're now incentivized to do more and more advice and guidance. And actually, I think the reasoning behind it is we do need to get a bit more advice before we do a full-on referral. But we do need to, I think we need to take a step back and actually, is what I'm asking for, is there something else where I can find that information through? So can we use AI in a triage type of capacity to kind of filter out some of those that we can find that information, as opposed to waiting 24, 48 hours for a cardiologist or any other specialty to come back to us, because that's also time out of their day. And actually information is available in many places. So can we pull on guidelines? Can we pull on any sort of frameworks that we can get that information ourselves and feel comfortable? I think a lot of the times my colleagues in general practice feel a lack of confidence in making some of those decisions themselves, and so they ask. So there's a bit of work looking at that, and there's also a lot of I wouldn't say a lot, but there's a bit of work looking at can AI agents help some of those referrals and all of that go through? Can we use AI agents to help some of the admin burden? Can we use AI agents to kind of bridge the gap between all of that? So I would say the thing we need to focus on is filtering what does need a genuine kind of specialist advice, and what could be kind of handled kind of internally. And AI, or some of the large language models, can potentially point to where we can find that information. Yeah. I don't want to say AI is going to make that decision, because it's not a lot of the AI tools are not, diagnostic medical devices that are regulated in that space, but you could hopefully look in that decision or in that direction.
I have got one question here about assessing. How often do we assess AI? Is it always being assessed? Because it's always like as it's real life data coming in, Mark. Do you assess it everything that comes in, or is it like a quarterly assessment on how AI performance has worked?
Well, I'm probably not best placed to answer this, because we probably operate a level lower than that with machine learning. So maybe Matteo or Eleanor might be better.
Yeah. What about assessing? Do you assess in real time AI performance? Whereas I've just lost it now.
I mean, certainly.
Yeah, go on, Nella.
Certainly we can chip in while you're having it. So for example, AI performance, because of its early stage in integration in clinical care, is very much monitored, I would say. And I think it's probably also, whilst we bring along clinical staff to feel more confident with the use of AI, we kind of need that cross-checking process. So I think we're in this stage where we could already see that AI is better at interpreting mammograms for breast cancers, for example, and x-rays, etc. So there is increasing evidence base for these, but I think the evidence base is what enables people to have the confidence to feel that you don't need to cross-check everything, but we're still in that in between.
Yeah, love it. And here's a question from Titch. If we assume the technology itself is not the limiting factor, it's a real barrier actually institutional incentives. For example, local trusts often bear the implementation risk while the benefits may occur elsewhere in the system. How should incentives be structured so organizations feel confident investing in AI at scale? Is that true? Is that sometimes what happens, where incentives go somewhere else other than where it's being implemented? Anyone?
I think there's quite a lot of there's a lot of incentive at the moment. I think for local teams to get involved. A lot of the innovation programs are to try and inspire and engage teams. Yes, there is a little bit of a postcode lottery with regards to, say, major academic centres, but there's a lot of AI work coming out across different centres, and I think perhaps where it may be more powerful is to try and facilitate the collaborative AI working rather than in silos according to different academic centres. Because to be honest, I think if you can bring together that expertise, we'll get much further, much more quickly. And so relating back to something that we mentioned earlier, rather than doing small studies in individual silos, actually centralizing some of these studies and trying to refine to specific areas to actually embed these studies properly, I think is really where we need to get to.
Definitely. So I'd just like to say thank you so much, Matea, Eleanor, Mystic Mark, and to Daniel. You have been absolutely awesome. I just think you've blown us out of the park. It's just been absolutely so good.